keynote presentation today is about pharmaceutical policy, access to medicines, and patient health outcomes, which at the end of the day are the most important to us. And then, of course, the burning million-dollar question: what is the future like? Now, let's see. For that, we'd have to ask a man with a lot of foresight and clairvoyance onto the stage. I'd like to invite Professor Dr. Zaheer-Ud-Din Babar, Professor in Medicine and Healthcare, University of Huddersfield, Director, Pharmaceutical Policy and Practice Center, author in Pharmaceutical Prices in the 21st Century, to come up on stage and enlighten us. Sir, all yours.
Bismillahirrahmanirrahim. Assalamu alaikum and very good morning, ladies and gentlemen and distinguished guests. Today I'm going to talk about access to medicines and pharmaceutical policy and patient health outcomes. What's the future like? Part of the presentation discussed the importance of medicine and how the medicine around the globe, they're being used and the access is being presented. And then there are a couple of examples which are related to low, middle, and high-income countries. Why we're interested in medicines? Because the medicines are the most common intervention and we use them properly in every field, in every way. Every time when you go and see a doctor, out of 10 times, if you're seeing a doctor, he would give you, as an intervention, 9 times he would give you a medicine. He wouldn't ask you to go for surgery, or he wouldn't ask you to go for other form of treatment. So medicines are the most important sort of treatment modality we have. There is a growth in terms of medicines expenditure. For example, there were $370 billion worth of expenditure in 2016. It's gone up to 1.5 trillion by 2021. So you can see sort of huge growth in this sector, which is about 3% annually. What we see is the biological and immunologicals and high-cost cancer medicines which are contributing to this growth. These are the figures we have from United States, which is the biggest sort of consumer and spender in terms of medicine, and followed by Canada, Japan, Europe, and the Pakistan, India, Bangladesh, which are sort of the subcontinent. They're at the down tier in terms of the per capita expenditure on medicines. What are the major sort of challenges we have with regards to medicine access and cost and things like that? Half of the medicine spending is in the US, as you can see, followed by the Europe, Japan, and emerging economies. There is especially medicine growth in cancer, diabetes, autoimmune disorders, and we have drug expenditures, not the prices per se, but the drug expenditures, which are actually rising faster than other healthcare costs in any other sector or any other countries. And the part of the reason is that we have high-priced medicines, and there is an aging population, and this is sort of a worldwide phenomenon, what we see. There is an increased demand for specialty medicines. We have consumers who are more informed. So nowadays, the consumers can actually go to internet and can search all sorts of medicines. And this is not putting a demand on even in the low and middle income countries, but also in high income economies, where actually the patients can go and see the doctor and ask for the newer treatments and for the newer medicines. So all these things are contributing towards having higher expenditure in the cost and things like that, which is putting the pressure not only in the low income countries, but also the high income countries, such as European Union, Japan, and United States as well. So in terms of access, we have this national medicines policy, and out of 200 countries in the world, majority of the countries, they do have a national medicines policy. And the component of this policy is to have access to safe, effective, affordable medicines. And the medicines should be of good quality. They need to be safe, they need to be effective, and they need to be accessible and affordable for the masses, for the majority of the people. And one component which I'm going to talk about is the access, which is a huge component, because about 1/3 of the world population, they do not have access to essential medicines. So this is the United Nations Sustainable Development Goals 3.8, which mentions the importance of access to safe medicines, and they need to be affordable to all. This is also being mentioned, as I said, it's a fundamental human right which is being enshrined in the constitution of many countries around the world. 4 million people, they lack access to healthcare, including medicines, and 300 of them actually live in the middle-income countries, the countries like Malaysia and Brazil and so on and so forth. This was a major issue in the United States elections, so where the hepatitis C treatment, which was going above over $1,000 per pill. And previously, this was an issue only in the low-income countries, but we increasingly see the high-priced drugs becoming a major issue in the European Union, where the cancer drug actually costs about 50% of the health budget in high-income countries as well. So this is no longer an issue which is the issue in developing countries or with the emerging economies. A couple of years ago, the leading medical journal Lancet, they commissioned essential medicines, and they were finding of the commission that you actually need $13 per capita to have a basket of 200 essential medicines. The expenditure, but even many of the low-income countries, they were not spending $13 per capita per GDP on buying pharmaceuticals. Not only low-income, but also 13 countries out of 47 middle-income countries were not spending enough on medicines. It's quite interesting to note, as you can see, the total expenditure on medicines in poor countries per capita on household was 9%, whereas in higher income countries, the poor households were spending 3%. So even the poorest of the poor in high income countries, they were spending less percentage on buying medicines, 3%, whereas in poor countries, people were spending about 10% of their expenditure on buying medicine. So this is a huge issue. So if someone is earning, 10,000 rupees or so you can calculate how much actually they're spending on buying medicine. A couple of years ago, we did a study on essential asthma medicines, and these are the sort of basic medicines such as salbutamol and terbutaline and things like that. So we looked at in 52 countries, low and middle income countries, and we published the findings in the essential report, and this is the sort of map of these countries. So what we see is that you can see a lot of red boxes here. So these red boxes are actually showing you the non-availability of essential asthma medicines, and these medicines were beclomethasone, salbutamol, which are very common off-patent generics and things. But with all these red boxes, you could see that the availability is really a big issue, not only in countries like Pakistan, but throughout the world, because these findings were published in a leading journal called Pharmacoeconomics. And we did have a sort of repetition of this survey, but we didn't find much of a difference. So if this is the thing in very commonly used asthma medicines, then perhaps you can think about what is going to happen with other medicines, which are more sort of specialized sort of treatment and things. And this was the availability of pharmacy, of beclomethasone inhalers in private pharmacies where the people really have to buy, they have to spend their monthly income actually to buy the course of treatment. And some of the countries you can see, they were sort of outliers in this coming through. The countries like Cambodia and El Salvador and South Africa and things. So South Africa could be something where you could have national health insurance, but not like countries like Colombia, where there were huge out-of-pocket expenses to buy these medicines. So the factors which could basically impact on, and I'm just going to touch base, I'm not going to go in detail, but I don't have much time, are the pricing, development of specialty drugs, generic medicines, R&D cost, and future medicine policy issues. And I'm going to quickly touch base some of these topics. And some of this data is coming from my own research, whereas some of this is actually coming from the literature. So the pricing is a huge issue. Yesterday we have a huge discussion section on that, and it's a growing challenge because the pricing is a major barrier to access in all countries around the world. What we see is the worrying trend at the moment, basically, is the prices of old drugs, and there is a growth in off-patent pharmaceutical prices. WHO essential generic medicines were sold in UK and South Africa about the price at 100 times the estimated cost of production, was really a sort of figure. You may have seen this where we see the Daraprim, which is a drug used to treat toxoplasmosis in immunocompromised patients. This drug was off patent about 60 years ago. It's been available, off patent since 70s. But Turing Pharmaceuticals in the United States, they hiked the price of the tablet from $13 to $750, with a 5,000 increase in the price of the drug. So we actually see this phenomena as well. Another point which is coming through, and this is again more of concern in the high-income countries where you have specialized insurance system in place, is the specialty drugs and cancer treatments and orphan drugs and things. So we see that the development of specialty drugs in the US FDA, the approvals have increased over 200% for the newer cancer medicines. And orphan drugs, the approval has gone up to 175%. And 65% of the new substances which are approved by FDA and European Medicines Agency and Health Canada, they were specialty drug. And that's actually where you would see a lot of prices up. For example, in mid-90s, for the multiple sclerosis in United States, you could have $8,000 a year. And in 2015, this has gone to $60,000. The newer cancer treatment in 60s were $100. In recent years in United States, which is a free market economy, that has gone to over $100,000 as well. Treatment of rare diseases is again something which is coming up, and an annual price for each patient to have a rare disease to treat is about $83,000. And this is a sort of an average, perhaps. One of the example is one of the cystic fibrosis medicine called Ivacaftor, which is about $300,000 per patient per year. So that's the kind of phenomena which the Western countries and the system where you have health insurance in place, these are facing. And one of the reasons that in United States, increasingly it's being said, is that we'd like to have this, is the research and development cost. But we'd like to see whether these costs, these are fair or not, or otherwise. It has been argued by the pharmaceutical companies that excessive prices and revenues are fair today because the development costs are higher. But one of the problems we have with the big pharma is that manufacturers do not disclose their research and development cost. And many of the orphan drugs are being funded by the companies, by the academic institutions, where the universities are actually paying for the clinical trials, for the data and things, and especially for the smaller trials, because especially for the orphan drugs, you didn't really need big trials, so you can actually do in smaller trial. So the cost of treatment, research and development cost in the case of orphan drugs is perhaps on the lower side. There is a big role of public and non-profit financing of research and development, which I would like to share with you as well, that there was a study in the United States, National Institute of Health, And they found out that they contributed, on average, for a drug, $839 million for a drug between 2010 to 2016. So there was a huge investment from the United States, and this was coming from, perhaps, from the public sector. The government also gave deductions in tax and tax credit, and this perhaps significantly contribute towards lowering the manufacturing development costs, particularly for the orphan drugs and things. So these are the sort of problems we have, but I want to touch base some of these problems again, and then perhaps what could be the solutions in this context. And yesterday we talked about, in detail, about this fair pricing model, and this model is just recently been suggested by Suri Moon, who is a fellow at the Harvard Chan School of Public Health, which actually takes a step further, looking at all sorts of costs and building in to have a fair pricing, and the prices which are affordable, but also it's conducive and it's supportive for the pharmaceutical industry as well. So at the end of the day, what are the mechanisms and what are the strategies which has worked? And the next couple of minutes or so, I'm going to share you some examples of the countries where what kind of strategies has sort of worked in the countries. And one of the things which has actually worked in a way is to regulate medicine prices. And we talked about this yesterday as well, that the various forms of price control are instituted. In majority of the countries, there are some countries which have direct form of price control, like Pakistan, and there are some other countries where you see indirect control, such as United Kingdom, France, Australia, and New Zealand. There are countries which actually have reference pricing and things. We did some studies. For example, this study which we conducted in Bangladesh by using a WHO and high pricing methodology 2 years ago, and it shows very reasonable prices in Bangladesh, except there were few outliers. And interestingly, these outliers were older drugs which were coming through. So one of the drug was benzoic plus salicylic acid, which you can see at the bar above there. But otherwise, their drugs were quite on the normal side. The affordability was good, but the main issue was the availability patterns in these countries. And I particularly want to share you the Pakistan study as well, where we have the drugs, and majority of the drugs were affordable, they were fine as far as their prices are concerned, but we have few outliers in case of some of the innovative brands, such as omeprazole and fluconazole and things like that. But other than that, you can see on the bar, and this was done through a WHO and high pricing method where the prices were benchmarked with the international reference prices. Whereas in some countries where there was free market economy and there was no control, we see huge prices. So where the market has sort of failed to bring the competition in, so we see the huge problems in terms of having large price differential and very high prices in these countries. And I'm going to show you an example of New Zealand, where we have the access to medicine and medicine pricing, and what are the different sort of strategies and models the New Zealand have used to actually promote access. The medicine use in New Zealand is about 870 million. This is the community pharmaceutical expenditure. 45 million prescriptions are funded in the country. And 3.68 million New Zealanders, they receive funded medicines out of 4 million population. And they do have a problem of high prices in the country before 1993. But in 1993, they actually sort of constituted an agency which is called Pharmaceutical Management Agency of New Zealand. And as a result of so the blue line is actually showing you the data if the Pharmaceutical Management of Agency would not have been constituted, and the red line is the actual expenditure. So basically, the Pharmac, after 1993, they enacted price control. They used the different sort of pharmacoeconomic strategies to have. So if you look at the blue line, you would see that the prices would have gone to, the costs would have gone to $2,590 million. But this was not the case. And this was perhaps on the lower end in 2018. So it was about $871 million. So what are the strategies they have used to control the costs and control the prices? So they basically used these three strategies to control, and these were economic analysis, the cost utility analysis, the generic medicines, which were used to promote the access and affordability, and controlling the pricing through the reference strategies. But one of the questions is that when you control the prices, does it have an impact on health outcomes? Or how do the patient feel about it? Is it okay? Is it right? So this is one of the questions which is being increasingly asked in New Zealand. That controlling drug expenditure and improving access, was it impacting on patient health outcomes or so? So there was some sort of criticism in the public domain that what Pharmac was doing it right or otherwise. So we looked at some of these components on these domains, and these were the framework which we adopted, and this was on generic medicines, what the general practitioners were thinking about, the access domain, and also on the medicine pricing. So what we observed, the studies we did, was that GPs were supportive, and they were supportive of the Pharmac strategies. They were satisfied with the range of medicines available in New Zealand, and there were general support for the Pharmac work. However, there were issues related to sole supply and availability of certain drugs. Also, we looked at the funding policies and availability in Australia and New Zealand, and Australia was funding more medicines as compared to New Zealand, but does it really have an impact on the morbidity and mortality data? In simple words, were the patient living longer in Australia because they were funding more medicines as compared to New Zealand? So there was no conclusive evidence that actually if you're funding more medicines, our patient would be living longer or otherwise, and so on and so forth. And we also looked at the pricing data on a leading article in Lancet, which we published. So we looked at the prices in the UK and in the New Zealand side, they were lower. And the price differential between the oranges to oranges and apple to apple, it was between 28 to 388% between the countries, which was really eye-opening. And this was happening because of the price secrecy and discrimination practices of the big pharma. It was observed that though the price secrecy and discrimination, it can reduce the price, the widespread use of confidential discount, it could impact on the health system. And as a result, some countries, low-income countries, would end up paying higher prices than the high-income countries for the same medicines, because of the price secrecy and discrimination and confidential discounts and things. Generic medicine is something which I quickly want to touch base for half a minute, because generics world over has produced and improved the affordability patterns. But the acceptance of generic is based on the physicians and pharmacists acceptability. So we conducted studies on consumers, physicians, and pharmacists. what we observe that the consumers have misconceptions about generics. Those educated consumers, if the people were educated, they were more able to try generics as compared to the ones who were not educated. We also looked at the doctor's opinion about generics, and we found that many of the doctors, they could not identify generic from innovative brand, basically. And the same were for the pharmacist as well, that only 1/3 of the pharmacists in New Zealand could identify the term generic medicine. And this is happening, this is the data from a highly developed country. So you can see what is the situation of generics misconceptions in the low and middle income countries as well. And the reason it's important because the generic policies have sort of been very effective to reduce the cost. And the generic acceptance of consumer directly depend on the physicians and pharmacists. So where we see the future is, of course, whether we talk about high-income countries or whether we talk about low and middle-income countries, the future is the affordability and access, and especially the lower socioeconomic circle is the affecting the most. We see the problems in the economic evaluation of new medicines, the cost-utility analysis, and this is happening in middle-income countries and high-income countries, but soon it's catching up to low-income countries too. We also see the problems in the genomics and patient subgroup profiling and the high-cost medicines and specialized medicines and treatments. These were the issues in one high-income country, but if you look at another high-income country, we see the same sort of issues as well. So we see the variability in access to medicines across all countries in United Kingdom and European Union and across different categories of medicines. And variability in access in United Kingdom was due to differences in reimbursement and pricing process, mandate of different agencies which are dealing in different United Kingdom countries, a difference in evidence requirement, interpretation of submitted evidence, and the lack of adherence with reimbursement and recommendation. So what is required to improve the situations? Of course, the key messages here are to new models to look at the pricing and affordability. The governments need to intervene to develop their capabilities, and the policies that extend intellectual property and limit price controls, they are sort of barriers in this context. So what we need to do, the key challenges, and this is sort of the last slide, is that to develop the capacity and the data in the low and middle income countries and also in high income countries to define and to do methodologically sound studies, conducting systematic reviews and meta-analysis, understanding the health systems, applicability and transferability of studies from a high income to low and middle income countries. We often see that there are similar issues in low and middle income and high income countries. However, the scale of the problem of availability and affordability, they may differ. Otherwise, we are on the same planet and we have the similar issue as far as the access to medicine is concerned. Thank you so much.